Okay, so now we're going to move from a syndrome where there's wasting of cysteine to one where there's accumulation. And so, again, Craig Langman will present on the topic of cysteinosis.
Thank you, Brad, and thanks, David, for setting the stage for cysteine. I'd like to thank the ASN for allowing me to discuss this cysteinosis. Here are my disclosures. So cysteinosis is a very rare autosomal recessive disorder. Can I see a show of hands for anybody who's actually seen a patient with cysteinosis? Okay, fantastic, great. And it's due to a dysfunction of the CTNS gene that transcribes the lysosomal protein cystinosin. That dysfunction of cystinosin, as I'll show you, leads to excess accumulation of intracellular cysteine in the lysosome because of reduced or absent transporter activity. And current therapies at the moment are limited to trying to deplete or reduce cysteine accumulation within the lysosome using cysteamine bitartrate compounds, and I'll show you that in a moment as well. The approach may not treat all the manifestations of the disease equally or at all. And kidney transplantation, remember, is not curative outside of giving the person a new kidney. Now, what is good is that since the majority of patients today with cystinosis have or will get a kidney, that is, they'll lose kidney function and require dialysis and transplant. If you happen to get a kidney transplant with cystinosis, the likelihood of you keeping it a long time is much higher than for all other kidney diseases that are known. Shown here in two analyses using all patients and those with excluding disease recurrence, where the red line is the lifetime likelihood of keeping a kidney transplant in cystinosis patients, the black line in all other patients. And in a multivariate Cox regression, they showed that cystinosis is quite protective. There is a bit of an immune dysfunction with this disease, and that may be a posited reason for that. We're not sure. Now, there really are two forms of nephropathic cystinosis you should know about. The first is well known to pediatricians. It presents early in infancy, usually within the first 2 years of life, with an early onset of failure to thrive, and everything else that's listed here. Importantly, the major cause of a renal Fanconi syndrome that's inherited is nephropathic cystinosis. Patients have an elevated white blood cell cystine level as the biomarker, and you can use that diagnostically to make the diagnosis. And most pediatricians will recognize it. There is, and we described, a late onset form of this disease where patients do not present with the nephropathic form in infancy. They do have corneal crystals, which is diagnostic. They do not have a complete Fanconi syndrome, generally just some proteinuria. They do get some of the target organ dysfunction like hypothyroidism, but generally have a preserved glomerular filtration rate. Importantly, if you did a biopsy in this disease, you might see focal segmental glomerular sclerosis. And so I want all of the adult physicians in the room, as well as the pediatricians, to think about FSGS as possibly being a late onset nephropathic cystinosis, and do a simple eye exam and look for the corneal crystals and not treat the patient as though they have a primary FSGS. Kidney variable is quite delayed. It may not occur at all, and again, the biomarker is present if you recognize the disease. Now, the manifestations of the disease are systemic, but they occur in different phases by age. Early on, in children with the idiopathic Fanconi syndrome from infantile form, GFR decline is generally by age 10, some photophobia from crystal deposition in the cornea. Other things happen later in the course, and there's this whole entity of what happens in adults. And what happens in adults is shown here from an old study from 2002 from Bill Gall, and hopefully a new registry that is starting will add some information to us about this. But the eye is affected, where you can have intense photophobia. Happily, there are now drops to take care of that. But you can actually get retinal blindness from crystal deposition in the retina. Endocrine organ dysfunction in untreated patients or poorly treated patients is very common, with hypothyroidism, diabetes, and male hypogonadism because of a defect in the vas deferens formation. Neuromuscular disease, patients often expire from a profound proximal and distal myopathy, and many neurologic complaints that you see here. So what happens? So in the normal circumstance, cysteine enters the lysosome, and it's transported out by this structure cystinosin. And the content of the lysosome intracellular cysteine is perfectly normal. So now, when it doesn't work because there's a dysfunction in the protein because of a mutation in the gene, there's an accumulation of cysteine within the lysosome, and that leads to all sorts of dysfunctions that I'll tell you about in a moment, including crystal formation in many organs, but not all. Cysteine simply crystallizes, as we heard about, in the urine, but rather than in the urine, it does it within the lysosome. Okay, so the way we currently treat patients is to try to remove that intracellular accumulation of cysteine. How do we do that? We give them cysteamine bitartrate. Here's that accumulation. We give them the drug cysteamine bitartrate, and that forms a complex with the cysteine in the cell, and it gets transported out by a member of the cystinosin family, but only working with a sulfhydryl disulfide mixed reaction. It's called PQLC2. And at the moment, it only works with the presence of cysteamine bitartrate and cysteine. It doesn't function under normal circumstances to transport cysteine out. And you can titrate your drug treatment to get the biomarker. The FDA at the moment says that in a mixed white blood cell preparation, that biomarker should be below 1 nanomole of cysteine per milligram of cell protein. So if you begin treating a few years ago, you had to use an immediate release cysteamine, which was given every 6 hours around the clock. If you did so, it absolutely reduces the accumulation of intralysosomal cysteine as measured by that biomarker in the white blood cells. No problem, it works. And in fact, if you can keep the level roughly below 1, it looks like kidney function is preserved for a longer period of time. And that's shown here where the biomarker level and the age of end-stage renal disease initiation using immediate release cysteamine. And this is in the American cohort. Here's a European cohort that shows essentially the same thing. If they started the drug by roughly age 2, and they could show that early treatment delayed the onset of end-stage renal disease, although generally still most patients receive a transplant. And the longer it took to get the drug, the more likely you were to get a kidney earlier in life. And that also correlated with their assay using a different white blood cell prep, a granulocyte preparation, to a level less than 3. But what's important is that if you can titrate the drug, you seem to protect the kidney and most other organs, but not necessarily all of them, especially the muscles. The trouble is that not many people maintain perfect compliance Q6 hours around the clock. This is from a review published recently from an anecdotal experience at the NIH. And if you look at the best controlled patients, out of all the patients, only 8 were able to maintain even moderate degrees of compliance. It's just very hard to do. So what's the problem? Well, with an every 6-hour drug, early in life, in infants, it's probably not a big deal. You do almost anything for your baby, right? But as life goes on, things happen. Lifestyle, adolescence is tough, and a lot of times people forget to restart the drug after a kidney transplant. So over time, retrospective database have shown continuing increases of that biomarker with the use of immediate release cysteamine. That was corroborated in a recent survey that was performed in Spain, where they show that up until adolescence, modestly good to fair adherence, and then it goes away after that. And in fact, there's even more reason to think about why a Q6-hour drug, even if you used it, probably wouldn't be a good thing, because that necessitates a middle-of-the-night dose all the time, every 6 hours. And this is not in patients with cystinosis, but in a recent study from the CRIC adult population, they correlated the fact that if you have poor sleep, not enough of it, and fragmented sleep, which absolutely would occur with a Q6-hour drug, there's faster progression to end-stage disease. And it makes sense that it would occur in any patient with chronic kidney disease, whether or not they have cystinosis or not. But I think it's another reason that it never made great sense, if we could do something else, than to use a drug every 6 hours. So there was a unique formulation that was started for having this drug packaged differently, cysteamine bitartrate, it's the same base compound, and it was now called delayed release, and that's shown here. So shown in blue is what happens when you use immediate release cysteamine. You take the drug, and within the first 30 minutes, an hour, you see a peak concentration. The new drug, delayed release cysteamine, I'll call it DR cysteamine, had a delayed onset of roughly 2 to 2.5 hours before it reached its peak, and the total area under the curve was equivalent to 2 doses of immediate release cysteamine, and therefore could be used every 12 hours. And that really made a big difference in the ability to be adherent to a drug every 12 hours, twice a day, as opposed to every 6 hours, 4 times a day. So we established immediately the non-inferiority of DR cysteamine compared to the immediate release cysteamine to control white blood cell cysteine in 43 patients who had the best control of their disease by the biomarker. So it was equivalent, non-inferior. And importantly, we could do this at a total daily dose of the drug which was less than the immediate release cysteamine. We only required about 82% of the total daily dose of the drug as delayed release. No new adverse effects were noted, and we performed then a 2-year extension study. So the 2-year extension study was also published, and what we were able to show is that using in a controlled prospective trial, that we were able to keep the biomarker in the optimal level of less than 1 that the FDA told us about. And we were able to do so over a continually reduced dose of the delayed release drug. We showed that in, these were mostly children, that their growth was preserved and that their kidney function also, for the first time ever in a prospectively controlled trial, was stable, except for 2 patients who went to transplant, 1 planned. So we've done subsequently multiple different studies. One of them was that because children under 6 can't take pills easily, we showed that there was bioequivalence if you opened the capsules and sprinkled it in applesauce, an acidic solution, and we transitioned those patients less than 6 from immediate release cysteamine, and we were able to show that they also had excellent results of biomarker control. And then we have a poster with Maria Helena Vesbich from Sao Paulo on Saturday that in treatment-naive patients, this is the first time we've been able to take de novo cysteinosis patients, never treated with any form of cysteamine bitartrate, and show that they also had excellent control of the biomarker and that the growth of these very growth-stunted children normalized after 18 months of this trial. So I want to end by telling you what lies ahead, because all of that is, it's better to take it every 12 hours than every 6 hours, and we are able to show pretty good outcomes. But what lies ahead? The first is that there's a great animal model of the what's called a European or Western mutation. It's a 57 kb deletion around the cystinosin gene. It's the most common in the Caucasian population. And there's a mouse model that Kiran Antanyak described, and Stephanie Cherky has made great progress in. In her model, in the mouse, you can actually cure the disease with bone marrow stem cell transplant. And there actually is now, will be shortly, an ongoing, hopefully starting clinical trial in humans to see if stem cell transplantation, autologous, with the gene being fixed, will cure this disease. Now, until that happens, and that's obviously in the future, there's some other things to think about. Francesco Emma, shown here, was the first to discover that there's actually a different isoform of the CTNS transcript cystinosin, and he called it LKG cystinosin. It's in a different part of the membrane than in the lysosome, and it's possible, using CRISPR-Cas9 technology, that cystinosin LKG could be a substitute for deficient cystinosin in the lysosome. And I think some of those studies are very exciting because that also would be a genetic cure in a different way. Now, one of the things that I think you've heard a lot about already at this meeting, you'll hear a little bit about more, is that we use autophagy all the time. Well, autophagy, just to remind you, is a normal physiological process that deals with destruction of cells in the body that allows circulation by protein degradation and turnover of destroyed cell organelles and being used again for new cell formation. During cellular stress, the process of autophagy is upscaled and increased and leads to destruction of target tissue. There's lots of evidence in cystinosis that there's a very high level of autophagy by multiple mechanisms I'd like to go through. Importantly, this is a picture of a swan neck deformity of the proximal tubule, which is the most severely affected initial portion of the kidney with that Fanconi syndrome in the infantile form. And there's lots of good evidence that I don't have time to talk about that there's a very high level of proximal tubule autophagy that leads to destruction of the proximal tubule, and once destroyed cannot really be repaired. First, Elena Levchenko, who might be in the audience, was first to show that the mTORC1, or mammalian target rapamycin complex 1, regulates autophagy in renal proximal tubule cells and is very abnormal in this circumstance. And she was able to show in an experimental model that you could, by restoring normal levels of that activity, you could lessen the degree of excess autophagy that's shown in this little graph with the reference here. So one thought would be, could we restore the mTORC pathway and reduce autophagy in cystinosis and prolong multiple cellular phenotypes working normally? Sergio Katz also showed that another form of autophagy called chaperone-mediated autophagy, which I don't have time to explain in any detail, is also quite abnormal in cystinosis. And he proposes, and that's really shown here, that you can find chaperone-mediated autophagy enhancers that would repair that underlying defect in the tissues with cystinosis and lead to improved tissue function and reduction in cysteine accumulation within those lysosomes. So that's also probably very exciting on the horizon. And lastly, there's a transcription factor called EB, which has been shown to be, when activated, because it's abnormal in cystinosis, also reduces intralysosomal cysteine accumulation. So 3 different ways that we might be able to affect autophagy and improve outcome. And lastly, Elena again invented a zebrafish model. As you know, zebrafish have the ability to respond very quickly to new novel therapies, and this really is a new era of thinking about such novel therapies in cystinosis, where you don't have to take the mouse and wait 6 months and see what happens. You can, in the matter of a week or 2, know what happens in the zebrafish. And she shows here in a publication that's referenced below that if you just put some of that cysteamine bitartrate in the water that the fish live in, you can have a reduction of the cysteine content of the target tissues that she studied. So in summary, there is absolutely good evidence that delayed release cysteamine using trial-based evidence has efficacy and safety for patients with nephropathic cystinosis, now of all ages, including infants. That a new model for cystinosis, in my view, the mutant zebrafish, offers easier testing methodologies for innovative treatments. And understanding the biology of cystinosin beyond cysteine crystal formation in the lysosome and its deficiency of those biologic actions has led to multiple new areas of cell biology which has involved. And modern technologies, including CRISPR-Cas9 editing, may be able to reverse some of the alterations and dysfunctions in those cell signaling processes we now recognize are part of normal cystinosin function. And in my view, the future for co-primary therapies for patients with cystinosis, in addition to cysteine reduction with cysteamine bitartrate, has never been more hopeful while we await the ultimate genetic cure. Thanks so much for your attention. I'm happy to answer questions.
Questions for Dr. Langman? Craig, I'll start off before adult nephrologists walk out of here. What do we do as far as these kids who are living longer and aging out of the pediatric centers? What do we need to ask of our adult nephrology colleagues?
Yeah, Brad, thanks. You know, there are more adults living with cystinosis in the United States than there are children at the moment I think that the adult nephrology community has to become a champion for the systemic disease this represents, and make sure that they have the appropriate ancillary subspecialties of pulmonology, neurology, and potentially physical medicine for their patients with cystinosis, because the kidney is going to work forever really well. It's the rest of the patient that's going to get in trouble.
Do you want to get up, Aura? And
I think the adult nephrology community has to add this subject to their curriculum and educate themselves about this disease, because we haven't got who to give our patients to when they outgrow the pediatric age group.
And that's why I'm so thankful the ASN has allowed this. Is there another question over there?
Yes, hi, I'm Catherine Garlow, Renal Fellow at Brigham and Women's Hospital. Thank you for your talks. I had a question. I was surprised by your graph showing cysteamine noncompliance after transplant. And could you elaborate a little more on what you think is going on there? Because I thought it was the standard of care to continue cysteamine therapy after transplant.
It should be the standard of care, but I think what happens, and luckily this is a nephrology meeting and all my transplant physicians are not here, but surgeons think, well, the patient had kidney failure from cystinosis. I gave them a new kidney. It can't recur in the new kidney, so therefore they don't need the drug. And actually that's the major reason I've heard why patients do not continue the drug. So I'd like it to be, it is standard of care in my mind and in your mind, but not in the real world, sadly.
Right. Okay. Thank you.
Thanks for your question.
Craig, do we see, with the effective drugs that we have, cysteamine and now procysbi, are we seeing any modification of the comorbidities? I mean, we can see longer function of the kidneys, but how about the other comorbidities that these patients endure?
Yeah, again, it's a bit anecdotal, Brad, but the average age of death has gone up considerably, and I have some patients who are in their late 40s, early 50s, and even late 50s now with the disease, where that was unheard of even 10 years ago. So we're making inroads, but I don't think that, especially the myopathy, which is a progressive one, is really as amenable to just cysteamine bitartrate depletion therapy.
Okay, any other questions for Dr. Langman or Dr. Sass?
I just want to always comment that the Fanconi syndrome, is a generalized amino acid urea, and you actually see levels of cystinuria, which are almost as high as in David's disease of cystinuria as a stone disease. The difference is that the patients have such a urinary concentrating defect that they have their own diuresis and they never form kidney stones from cysteine.
Good point. Oh, one last question?
Yep, I'm from Sheffield in the UK. A question for Dr. Sass. You didn't talk about the timing of your treatment to the patient. I mean, most patients struggle to drink overnight, and if you do a split 24-hour urine collection, you certainly see the concentration is often much higher during the nighttime period than the daytime. Do you therefore advise the treatment at night, or do you not bother?
So the question is about, do I ever advise treatment at night for patients, given that if they're going a long period of time without drinking water, that is the period of time when they're at the highest risk for stone formation. I take a practical approach to it. If we're able to achieve the desired results by drinking during the day and water just before bed and water upon waking up, great. But there are cases that are so severe, for instance, in infants or small children, where we'll even have the surgeons put in a G-tube and give water that way. So we try to, the philosophy of the approach is to do just what you need to do to get the desired effect. If that's not cutting it, then you get more aggressive and essentially more invasive. So there are cases where I have parents either wake their children up to drink in the middle of the night, or even have a G-tube placed. I try not to do that. That's not the starting point. That's only if more reasonable measures are not cutting it.
Okay, thank you very much all for your attention and your interaction, and have a good day.